1 second. That is exactly how long it takes for a splash of boiling water to cause irreversible full-thickness cell death.
Yeah, it is terrifyingly fast.
Right. Welcome to this revision deep dives. Today we are tearing into the clinical assessment and the acute management of major burns.
And we are keeping this high yield. This is purely clinical.
Exactly. This is designed specifically to get you ready for your plastic surgery board exams, like the FRCS.
So we are skipping the fluff.
Getting straight to the physiological mechanisms and the surgical interventions that you will absolutely be tested on.
Right, so hit that follow button right now so you do not miss any future revision deep dives.
And hey, if you learn a concept today that, saves you an Aviva, leave us a rating.
Definitely.
So before we even touch on how tissue burns, we really need to establish the sheer scale of the stakes here.
Oh, the historical data is wild.
Right. If you look at the numbers, the odds of surviving a massive burn have shifted so radically, haven't they?
The velocity of medical progress in this specific field is just incredible. Consider a young adult patient who comes in with a 50% total body surface area burn, so TBSA.
Right.
25 years ago, that patient faced a 50% mortality rate. It was a literal coin toss whether they lived or died.
Then a coin toss.
Literally. But today, with modern management, the mortality rate for that exact same 50% TBSA injury has plummeted down to just 10%.
Wow. Which completely changes the nature of the conversation we have with the patient's family.
Absolutely.
But what about the truly catastrophic injuries? The ones covering almost the entire body.
Even those numbers have completely transformed. A decade ago, an 80 to 90% TBSA burn had a survival rate of barely 10%.
Just 10%.
Yeah. Today, that survival rate has climbed to greater than 50%.
That is amazing. But human skin hasn't evolved in the last 10 years.
No, it hasn't.
So what is the mechanism behind that survival shift? What are the specific interventions driving those numbers down?
Well, the improvement really rests on 4 distinct pillars of management.
Okay, let's hear them.
First, advancements in protocolized fluid resuscitation. Second, highly aggressive and early surgical techniques.
Right.
Third is the targeted management of sepsis. And fourth, sophisticated nutritional and metabolic support.
Got it. So those 4 pillars are the foundation of modern burn care.
Exactly.
Those pillars make sense broadly, but to understand how to apply them, we have to zoom all the way in.
Right, down to the tissue.
Yeah, we need to look at the cellular level of the thermal injury itself. Let's talk about the pathophysiology of that damage.
Because the degree of necrosis is a function of both temperature and duration of contact.
Right. We mentioned boiling water at 1 second causes a full-thickness burn. But what happens at just a fraction of a second?
Well, exposure to boiling water for just 0.1 seconds causes a partial thickness burn.
Oh.
It is so fast. And it's crucial to remember that lower temperatures are just as dangerous if the contact time is prolonged.
Oh, well, like the classic exam scenario with the radiator.
Precisely. A patient, maybe someone who has collapsed or is obtunded, resting against a radiator at just 50 degrees Celsius will sustain a deep burn if they can't pull away.
I want to look at how we conceptually map that local tissue damage, specifically Jackson's burn wound model.
Oh, heavily tested.
Very. And often it's taught like a bomb blast, radiating outward. But I always the better analogy is cooking a steak on a high-heat grill.
I actually love that. That is a much more accurate physiological comparison. Break down the layers of that steak analogy for us.
Right. So where the meat touches the grill, it is totally charred. That ground zero is the inner zone of coagulation.
Which is irreversible cell death.
Completely. The heat has literally denatured and coagulated the cellular proteins, just like cooking an egg white. Nothing survives there.
Nothing.
Moving outward, the middle layer of the steak is the intermediate zone of stasis. The tissue here is damaged, the microcirculation is sluggish, causing severe ischemia.
And then the outermost ring.
Finally, the outermost edges are the outer zone of hyperemia. This is where cellular damage triggers the massive release of inflammatory mediators.
Like histamine and free oxygen radicals.
Yep, and arachidonic acid breakdown products. Those mediators force massive vasodilatation and increased vessel permeability.
Now, the absolute key clinical pearl you need to pull from that model for the boards involves that middle layer.
The zone of stasis.
Yes. Because the microvasculature there is sluggish and sludgy, the tissue is highly ischemic. But it is salvageable.
That is the operative word.
Its ultimate fate, whether it recovers or dies, depends entirely on your fluid resuscitation.
But wait, if the vessels in that zone are already damaged by the heat, How does pumping the patient full of intravenous fluid actually save the tissue?
Because you are fighting to maintain perfusion pressure.
Oh, I see.
The fluid leaking out of that hyperemic zone causes local hypovolemia and thickens the blood in the surrounding capillaries.
It gets sludgy.
Right. If you under-resuscitate, the perfusion pressure drops too low to push blood through those sluggish capillaries in the zone of stasis.
And then what?
The microcirculation thromboses, the ischemia becomes absolute, and that salvageable tissue undergoes irreversible necrosis.
Meaning your full-thickness burn just expanded significantly.
Exactly. You lost the battle for that tissue.
Wow. So we have this local area of damage, a massive fluid leak, and a surge of local inflammatory mediators.
Yeah.
But because the body is a closed system, at some points that local injury scales up. What is a specific threshold where a burn stops being a local wound and becomes a systemic crisis?
The golden threshold you need to know is greater than 25 to 30% TBSA.
Cross that line and a local burn becomes a whole-body systemic disease.
Correct.
Why does the system fail at that specific percentage, though? What is physically happening?
Think about it conceptually. At 25 to 30% TBSA, that outermost zone of hyperemia is now massive. It's covering a third of the body. The sheer volume of inflammatory mediators being produced, specifically tumor necrosis factor, interleukins, and interferon, it's just too massive to stay localized.
So they overspill directly into the systemic circulation.
Precisely.
I always found the resulting cascade so counterintuitive.
How so?
Well, we know these mediators cause profound capillary leak, leading to hypovolemia, right?
Yeah.
The fluid is physically leaving the blood vessels and pooling in the interstitial space.
Right. Massive third spacing.
But another huge consequence is myocardial depression. If the patient is severely hypovolemic, wouldn't the heart be desperately trying to pump faster and harder, not becoming depressed?
You would definitely think so. But the circulating cytokines, particularly TNF-alpha, have a direct, toxic, stunning effect on the myocardium.
That is brutal.
It is. So right when the body needs maximum cardiac output to compensate for the hypovolemia, the heart muscle is biochemically depressed.
It's a total system failure.
Complete.
You have a stunned heart, you develop pulmonary edema from the systemic capillary leak, renal impairment from the lack of perfusion, and hepatic dysfunction.
Not to mention massive catabolism.
Oh yeah, the systemic inflammation triggers that. The body's metabolic rate skyrockets, and it literally starts cannibalizing its own muscle to fuel this hyperinflammatory state.
On top of that, you see severe immunosuppression and a complete loss of the gut's protective barrier function.
Which brings us to the surgical solution. The patient's body is effectively poisoning itself with its own inflammatory response.
Exactly. And the primary way we arrest that cascade is early excision and closure of the burn wound.
You have to physically, surgically remove the tissue that is acting as the factory for those inflammatory mediators.
Get the dead cytokine-producing tissue off and get the wound closed.
Right. Now, assuming the systemic cascade is already underway, let's walk through the immediate protocol when a major burn patient actually rolls into the trauma bay.
Okay, your absolute first priority is identical to any other major trauma.
Strictly ATLS protocol.
Always. Airway always comes first. You must assume an inhalation injury until proven otherwise.
Right.
If the airway patency is at risk, or if you anticipate significant edema developing, you secure the airway with early intubation.
And there is a massive clinical trap here regarding that endotracheal tube.
Oh, yes, there is.
Normally, after intubation, the tube is trimmed at the lips so it doesn't flop around or get dislodged.
Right.
But if you intubate a burn patient, you absolutely do not cut the tube.
Walk everyone through the mechanics of why that is so dangerous.
Because the massive fluid shifts we just discussed are going to cause extreme third spacing in the tissues. The patient's face will swell dramatically over the next few hours, often literally doubling in size.
It's astonishing how fast it happens.
Yeah. And if you trim that tube flush with the lips upon arrival, the subsequent facial swelling will completely engulf it.
You lose access to the tube port.
Yep, it disappears inside the swollen tissue of the mouth. You lose the airway in a patient who is now anatomically impossible to reintubate.
Such a critical save. Let's look at another really common clinical trap.
Lay it on me.
A patient is brought into the ED 15 minutes after a major burn, and they are in profound hypovolemic shock. Their blood pressure is in the boots. Is the acute burn causing that immediate shock?
No, Profound hypovolemia in the immediate acute phase is almost never caused by the burn itself.
Exactly.
Burn shock is a result of fluid shifting from the intravascular space to the interstitial space, which is a process that takes hours to reach its peak.
Right.
If a patient is hypotensive the minute they hit the trauma bay, the burn is a distraction. You must look for coexisting polytrauma.
They have a ruptured spleen, a pelvic fracture, or some other source of internal hemorrhage.
You'd have to rule that out first.
Yeah.
So we deal with immediate life threats via the primary survey. What are the specific rapid-fire protocols for the rest of the burn-specific ED admission?
Well, you assess the cutaneous burn only after the secondary survey is underway.
Once you expose the patient to estimate the TBSA, you need 2 large-bore IV cannulas to initiate fluid resuscitation.
And yes, if the only accessible veins are under burnt skin, placing the cannula straight through the burn is perfectly acceptable.
It's necessary. What about internal monitoring and support? We are placing 2 specific tubes, right?
Yes. First, you insert a urinary catheter. This is mandatory because hourly urine output is the most reliable clinical indicator of end organ perfusion.
It tells you the adequacy of your fluid resuscitation.
Exactly. Second, you insert a nasogastric tube to decompress the stomach.
But the NG tube serves a dual purpose. It allows you to start early enteral feeding
Why is early enteral feeding so vital in the acute phase?
to protect the gut mucosa. During hypovolemic shock, the body shunts blood away from the splanchnic circulation.
Right, survival mode.
The gut becomes ischemic, and the mucosal villi can rapidly atrophy. If that barrier breaks down, bacteria from the gut translocate directly into the portal circulation.
Driving a massive secondary sepsis.
Exactly. Early feeding maintains blood flow to the gut and preserves that mucosal barrier.
Vital. And finally, for the wound itself, we initially cover it with cling film.
Right. Cling film provides 3 distinct physiological benefits in the ED, doesn't it?
It does. First, it halts evaporative fluid loss from the exposed dermis. Second, because it is transparent, it allows continuous visual reassessment of the burn without having to painfully tear off adherent dressings.
Oh, it's huge.
And third, simply covering the exposed nerve endings away from the air currents provides significant pain relief.
So simple but so effective. Once the patient is stabilized and the cling film is on, we move to the AMPOLE history.
Right.
History taking here must be surgically precise because it dictates your prediction of the burn depth. Let's start with scalds. We don't just ask if it was hot liquid.
No, you need to establish the exact thermal capacity of the liquid. How recently had the kettle boiled? Did they add cold milk to the tea before it spilled?
Right.
Critically, you must ask what exactly was in the saucepan. Soup, oil, and boiling rice boil at significantly higher temperatures than water.
Furthermore, they have a higher viscosity, meaning they stick to the skin rather than running off.
Exactly, which drastically increases the duration of thermal contact and the depth of the burn.
For electrical injuries, we need 3 key pieces of information.
Go ahead.
The voltage, to differentiate domestic from high-voltage industrial injuries, whether there was an associated flash, and whether the patient's clothing caught fire.
Which adds a secondary thermal flame burn to the primary electrical injury.
Yep. And for chemical injuries, you must identify the specific chemical agent, the exact duration of exposure, and whether any specific antidotes or irrigation protocols were initiated at the scene.
Because giving too much fluid based on a wrong visual estimate can literally drown the patient's lungs, we need a mathematically precise way to measure the burn area.
This is where people mess up.
Mm.
When we are estimating the surface area, do we include erythema, the red sunburn-like appearance in our TBSA calculation? Say it again for the people in back.
Never include erythema. It represents superficial vasodilatation, but it is not a structural burn that requires systemic fluid resuscitation.
Erythema fades within hours.
Right. Including it in your calculation will cause you to wildly overestimate the TBSA, which means you will pump massive amounts of unnecessary crystalloid into the patient.
Driving pulmonary edema and compartment syndromes.
Exactly.
So what are the primary methods for calculating TBSA? Let's start with the fastest way to estimate patchy, irregular burns.
The palm method.
Right.
The area of the patient's palm, importantly, with the fingers adducted and held tightly together, represents approximately 0.8% of their TBSA.
You use this to estimate scattered burns. Or in massive injuries, you use it to measure the islands of unburnt skin and subtract that from 100%.
Exactly. Then we have the Wallace Rule of Nines, which is heavily tested.
Heavily. How does the calculation shift between an adult and a 1-year-old child?
Well, in an adult, the head and neck is 9%. Each entire arm is 9%. The anterior trunk is 18%. The posterior trunk is 18%.
And the legs.
Each leg is 18%, and the perineum is 1%. But an infant's anatomy is completely different, right? Their head is disproportionately massive compared to their limbs.
So how does the math actually change for a 1-year-old?
The infant's head and neck accounts for 18%.
Double the adult.
Right. The trunk and arms remain the same as an adult. But because the head took an extra 9%, we subtract from the legs, making each leg only 13.5%.
And as they grow,
As the child grows, for each year up to age 10, you subtract 1% from the head and neck and distribute 0.5% to each leg.
which is why the Lund and Browder charts are the gold standard graphical record.
Yes.
They automatically adjust the surface area percentages based on the patient's age,
Yeah.
completely removing the mental math errors.
Which is safer. So we have the surface area. Let's move to depth assessment.
Okay.
The unbreakable rule here is that you cannot accurately stage a burn through a blister.
You must de-roof the blister and assess the base of the wound.
Always. Let's run through the clinical presentations.
Okay, hit me.
You de-roof a blister, and the underlying tissue is pink, moist, it blanches rapidly with pressure, and it is excruciatingly painful for the patient.
You are looking at a superficial dermal burn.
Right.
The microcirculation is intact, hence the blanching. The nerve endings are exposed but alive, causing the severe pain. This will heal spontaneously.
Correct. Next scenario. The wound base is mottled white with cherry red fixed staining. Sensation is dull and the tissue does not blanch.
That is a deep dermal burn. The lack of blanching tells you the dermal microcirculation is destroyed.
And the staining.
The cherry red fixed staining is hemoglobin that has leaked from heat-ruptured red blood cells into the interstitium. Because the deep dermal elements and vascular supply are compromised, this will not heal on its own without severe scarring.
Perfect. Final scenario. The tissue is leathery, it is white or yellow, completely insensate, and obviously does not blanch.
Full thickness burn. The nerve endings are entirely destroyed, which is why there is no pain in the center of the wound. The entire thickness of the skin is dead.
Exactly. Now, since clinical assessment can sometimes be equivocal, especially between superficial and deep dermal, we often use laser Doppler imaging.
Right. It measures the microvascular blood flow within the wound bed, which correlates tightly with the burn depth, completely removing the clinical guesswork.
The destruction of that dermal layer brings us to one of the most critical surgical interventions in the acute phase.
The escherotomy.
Yes. Deep dermal and full-thickness burns destroy the natural elasticity of the skin. The dead tissue, the eschar, becomes rigid and unyielding, like a tight leather boot.
Which creates a massive mechanical problem when you start pumping the patient full of resuscitation fluid.
It does.
What are the two distinct clinical scenarios where an escherotomy is absolutely mandatory?
First, when circumferential burns on a limb act like a tourniquet, causing distal ischemia.
Right.
Second, when extensive full-thickness burns of the anterior chest or the abdomen in a small child impair ventilation because the chest wall physically cannot expand outward against the rigid eschar.
It is vital to understand that this constriction does not happen the moment the patient is burned,
No, it gets progressively worse.
specifically because of our fluid resuscitation. You're driving massive amounts of fluid into the patient. As the tissue underneath that rigid leather eschar begins to swell with edema, the pressure has nowhere to go but inward.
It compresses the thin-walled veins first.
Exactly. Halting venous return, which drives the swelling even higher until arterial flow is completely occluded.
So we have to cut the eschar open to release that pressure.
And you typically use electric cautery, not a cold scalpel.
Right. You are incising through insensate dead tissue, but you must cut deep enough to reach viable, bleeding subcutaneous fat to ensure the release is complete.
The electric cautery allows you to manage the resulting hemostasis. Where exactly are we making these incisions on the limbs?
Incisions are made along the midaxial lines of the limbs. Placing them midaxially avoids the major neurovascular bundles running down the anterior and posterior compartments.
So there are danger zones.
Yes, you must meticulously avoid two specific danger zones. The ulnar nerve, as it passes behind the medial epicondyle at the elbow, and the common peroneal nerve, as it wraps around the fibular head at the knee.
And just to clarify for the boards, an escherotomy only cuts through the burn eschar. We are not routinely cutting open the deep muscle fascia.
No, fasciotomies are generally reserved for burns that directly involve the muscle compartment or high-voltage electrical injuries where the deep tissue destruction is massive.
What about the mechanics of releasing the chest? If a patient's lungs cannot expand against a full-thickness torso burn, where do you place the escharotomy incisions?
You make vertical incisions down the bilateral mid-axillary lines, extending to the subcostal region. You then connect those two vertical lines across the upper abdomen with a transverse chevron incision that runs parallel to the costal margins.
The physiological goal there is to create a mobile breastplate.
Okay.
By cutting the lateral and inferior borders, that rigid square of burnt tissue on the anterior chest is freed from the surrounding skin. It can now heave outward with every inspiration, allowing the lungs to expand.
But since the patient is intubated and sedated in the operating room, you can't exactly ask them to take a deep breath to see if it worked.
Right.
So how do you clinically confirm that the chest escharotomy was successful?
You look over the ether screen to the anesthetist. They're watching the ventilator.
Yep.
The moment you complete that lower chevron incision, the mechanical restriction is released, and the anesthetist will report a sudden, dramatic drop in the peak airway pressures required to ventilate the patient.
That is exactly what you want to hear.
That brings us to the end of our outline. We have driven through the mechanisms behind the shifting survival rates, the microcirculation of Jackson's model, the systemic cytokine cascade, and the precise execution of ATLS protocols, TBSA mathematics, and surgical decompression.
Grasping the physiological why behind these protocols is what will separate you from the pack during your boards.
Absolutely.
I want to leave you with a final thought to mull over for your vivas.
Let's hear it.
We established earlier that a 1-second exposure to boiling water causes a full thickness burn. I want you to consider the physics of heat transfer.
Okay.
Think critically about how the varying thermal capacities and conductivities of industrial chemicals, molten metals, or superheated gases might radically accelerate that initial 1-second timeline for the zone of coagulation. The physics of the specific agent changes everything about the depth of injury.
That is a brilliant concept to explore further. Listeners, if you want to elevate your board preparation and clinical understanding to the absolute highest tier, you need to get a premium subscription to the show right now.
Highly recommend it.
That subscription is your direct access to our exclusive journal club and our in-depth clinical cases deep dives.
Yep.
You do not want to walk into your final exams without those in your arsenal.
We also really want to hear from you. Please leave a comment or a question wherever you are listening. Share your own study takeaways, or let us know what physiological concepts from today's session are still giving you doubts.
We read them all and use them to shape future discussions. Stay sharp, trust the physiology, and we'll see you on the next deep dive.